Myself, Dr. Neerav Panchal, Professor, Cardiovascular and Thoracic Surgery Department, working in UN Mehta Institute of Cardiology and Research Center. And today we will discuss empyema and its management. Now, empyema, as the name suggests, it's the collection of pus in the pleural space. Now, different types of empyema, as we know, that is parapneumonic empyema, tuberculous empyema, and surgical empyema. The parapneumonic empyema, it is associated with the pneumonia or pneumonitis, or sometimes the lung abscess complicates the parapneumonic empyema. Tuberculous empyema, it is basically the infection of the pleura by tuberculosis, and surgical empyema, it is either after the surgery like lobectomy, pneumonectomy, such type of pulmonary resections, hydrated surgery, or sometimes it is after cardiac surgery, esophageal surgery, or rupture of the abdominal hollow viscus. So basically three types of empyema: parapneumonic empyema, tuberculous empyema, and surgical empyema. Out of this we will discuss today parapneumonic empyema and tuberculous empyema. Parapneumonic empyema, it is secondary to lobar pneumonia, pneumonitis, or complication after lung abscess. Incidence wise, if we see 20 to 40% of all the pneumonia, they get converted with pleural effusion. Out of this, 5 to 10% they develop empyema, and out of these all empyema cases, 30% require surgery. Now, if you see the pathogenesis of empyema, there are three different phases. The first phase is exudative phase, second is fibropurulent phase, and third is fibroelastic phase. In the exudative phase, there is a rapid outpouring of the fluid in the pleural space. It is either due to increased pulmonary interstitial fluid or increased permeability of the pleural capillary. If we see bacteriologically, this collection is negative by bacterial culture, but the pH is more than 7.2 and glucose content is more than 60 mg per dl. When this pleural effusion persists, after exudative stage, it gets converted into the fibropurulent stage. In this stage, the fluid becomes infected and gets loculated. It is bacteriologically culture positive, with the pH is less than 7.2 and glucose content is less than 60 mg per dl. If this loculated collection further persists, it ultimately gets converted into fibroelastic stage, where there is ingrowth of fibroblasts from both the parietal and the visceral pleura, and which forms a thick pill around the lung, which causes entrapment of the lung, and ultimately it prevents lung expansion. So three different phases: first phase exudative phase, second is fibropurulent phase, and third is fibroelastic phase. Another nomenclature, if we see for parapneumonic empyema, is acute and chronic. In the acute stage, if the parapneumonic empyema is less than of 6 weeks duration, we can say it's acute stage. In this stage, the infection spreads from the pneumonia to the pleural space by lymphatics, by hematogenous spread, or due to rupture of the necrotic parenchyma, and which ultimately causes infection in the pleural space. If this collection persists for more than 6 weeks, it is called as chronic empyema. It is either because of untreated or inadequately treated acute pneumonia. Sometimes what happens, this empyema in a later stage causes erosion of the lung parenchyma, and ultimately it drains into the bronchiole or any of the segmental bronchus. Then it is called as, the term is called as bronchopleural fistula, and we can find the patient with empyema complicating bronchopleural fistula with a copious amount of foul smelling sputum. And sometimes this collection empyema, it drains into the subcutaneous space and ultimately gets eroded into the skin. It causes empyema necessitans. If we see bacterial etiology for parapneumonic empyema, in early phase, before the injudicious use of widespread empirical antibiotics, the Streptococcus, Pneumococcus, and Staphylococcus, they were the most common organisms which were found in the culture of parapneumonic empyema. But nowadays we are seeing more and more cases of gram-negative as well as anaerobic organisms causing parapneumonic empyema. If we see the clinical presentation, the patient will develop cough, fever, chest pain, patient will have breathlessness, anorexia. All these are overlapping symptoms along with the pneumonia. As we already have told, the bronchopleural fistula, if the patient develops BPF, there will be copious foul smelling sputum with a chronic cough. If we assess the pleural fluid, we can get the reports for culture. Bacteriologically, if the repeated samples are negative, then we must also think of tuberculosis or fungal etiology. We can find out pH, glucose and LDS level from this pleural fluid. If you see radiologically, the X-ray will show the picture of consolidation and pleural effusion. It is known that approximately 175 to 200 ml of fluid is required to produce opacity on a chest X-ray. Mostly this collection gets loculated and it becomes a lenticular shape. If the thickness is more than 1 centimeter, it is said that this collection can be aspirated and we can send for investigation. Now as we can see the both X-rays on left side, we can see there is a lenticular opacity on left lower zone, and on right side there is a opacity because of the loculated medial empyema. Here the empyema has been treated with ICD on the left side, but the lung is not getting expanded and there is clear-cut air fluid level with a thickened pill over the lung. On right side we can see different collections with air fluid level due to a large empyema. Now if we go for sonography, this ultrasonography will tell us the amount as well as there is presence of septations, loculations of this empyema. It will help us to assess whether the lung is collapsed or not, and it will help us to guide for aspiration for thoracocentesis or ICD insertion. If we go for CT scan, different important parameters we can assess by the HRCT. We can get the empyema volume, the exact site, location and the number of the empyema collections if they are loculated. Plus we can assess the pleural thickness, we can assess the parenchymal pathology, associated consolidation, lung abscess, any pulmonary tuberculosis, associated bronchopleural fistula. We can also assess the presence of air bubble in the pleural effusion, which is a clear-cut indication of empyema, as well as we can see the split pleura sign, which is the hallmark of empyema on CT scan. So these are different CT pictures. On left side we can see a clear-cut split pleura sign for empyema. Here also we can see two different collections, and on right side we can see a lenticular opacity, which is the fissural empyema. Here again we can see a clear-cut demarcated empyema with a calcified pleural pill which is entrapping the empyema cavity. Though MRI is not very useful, but we can get the assessment of extent of empyema in the soft tissue like chest wall and spinal column. Bronchoscopy, yeah, it is one of the most important investigations to get the bronchoalveolar lavage for culture. We can assess bronchopleural fistula if present. We can also get to know about the endobronchial spread of the tuberculosis and any intrabronchial endobronchial mass lesion which is causing obstruction and which ultimately causing collapse of the lung, pneumonia, and ultimately complicating empyema. So we are coming to the management of parapneumonic empyema. Basically, three principles are followed for management of parapneumonic empyema. First is control of the infection and sepsis with antibiotics. Second is evacuation of the pus from the pleural cavity, and the last is obliteration of the cavity and re-expansion of the lung. But sometimes what happens, this lung is not getting properly expanded, then other methods are required, which we'll show later on. Now the guidelines for acute pleural empyema antibiotic treatment, what are the recommendations? The recommendation is class 2A for community acquired empyema, parenteral second or third generation cephalosporin with metronidazole, or parenteral aminopenicillin with beta lactamase inhibitor. Another class 2A is for hospital acquired or post procedural empyema. They include antibiotics active against MRSA and Pseudomonas aeruginosa like vancomycin, cefepime and metronidazole, or vancomycin and piperacillin tazobactam. Class 1, avoid aminoglycoside for management of empyema. Class 2A, there is no role of any intrapleural administration of antibiotic. Now, for the duration of antibiotic therapy, the recommendation is acute bacterial empyema is the duration has to be as long as the acute bacterial empyema is influenced by the organism, adequacy of the source control and clinical response. So we need to see all these things and we need to continue up to that duration. Now the first aspect is the observation and use of antibiotics with the medical management. Many of these parapneumonic empyema, they in the early stage, in the acute stage, respond well to these antibiotics if used properly with the bacterial culture targeted organisms, and they recover very well. In thoracocentesis, we can in the either directly or USG guided, we can get the sampling and we can send for the culture which is therapeutic or diagnostic. We can use this thoracocentesis procedure and we can manage along with antibiotics. Sometimes ICD insertion, if the collection is more, we need to use intercostal drainage tube. Commonly 28 to 36 French ICD is used. And these patients, after insertion of proper ICD, they respond very well within 24 hours of the ICD insertion and proper antibiotics. But sometimes what happens, the patient is not recovering even after 24 hours, then we need to think what is happening. Sometimes what happens, either the wrong position of the intercostal drainage tube, there are septations which are not allowing proper drainage of the collection, or after drainage the lung is not getting properly expanded because a thick fibrous pill which is covering the lung. So these are the things we need to keep in mind after insertion of ICD. ICD we can use directly or under USG guidance. Intrapleural fibrinolytics, they are used sometimes. They say the use of streptokinase 2.5 lakh units or urokinase 1 lakh units. They can be inserted through ICD in the pleural cavity. What they do is they help to cause lysis of the clots, membranes, increased fluid, they prevent the increased fluid sequestration, and they help the increased drainage of the empyema. So these are the things, these are the modes we keep in mind during treatment of empyema. Now coming to surgical side, if we go either the video assisted thoracoscopy or open thoracotomy, we can plan for the management of empyema. In the vets with adhesiolysis, if the empyema is of less than 6 weeks duration, we can plan out the vets procedure with the disruption of the loculations, drainage of the cavity, and ultimately insertion of ICD, which help to further drainage of the pus in the postoperative phase. But if the pleura is very thick and the lung is not getting expanded, we need to go for decortication. We'll see the video of vets after the completion of this lecture. if the patient is not responding either with the antibiotics, ICD, wet cytolysis, ultimately because of the thickened pleural pill, he will require a decortication in the form of removal of fibrous tissue from the visceral pleura, parietal pleura, and evacuation of the pus from the cavity, and we can get the satisfactory expansion of the lung. Few other procedures, sometimes when the patient is very ill, for VATS or thoracotomy, then a small procedure called as open drainage, in which we excise 1 to 3 ribs over the empyema cavity and put a ICD, 1 or 2 ICD through the same incision, and we allow the drainage of the pus after applying a colostomy bag through the ICD site. And with this method and continuation of antibiotics, the patient responds well. But another method is, sometimes what happens, we can, because of this open method, the patient may not find very cumbersome. It will be a very cumbersome method for the patient, and he will not like to change the dressings or managing the colostomy bag at the ICD sites. Another small procedure is a Ehlers flap, in which creation of a track between pleural space and skin with the muscle flap, which acts as a controlled fistula and allows the growth of granulation tissue in the empyema cavity, which ultimately heals over a period of time. So these are the procedures and management of empyema. On the right side, we can see the stage 2 or stage 3 empyema requiring surgical intervention. If the patient is good enough to tolerate single lung ventilation, we can plan out VATS procedure, and if we achieve full evacuation with the full lung expansion, we can manage this patient with VATS procedure. If he is not able to expand the lungs fully, we may need to convert him for thoracotomy. Or if the patient is not able to tolerate the single lung because of the very poor pulmonary functions, then we need to plan out thoracotomy in initial phase only. Now coming to the second empyema is the tuberculous empyema. As we all know, 5% of all the pulmonary tuberculosis, they develop pleural effusion. But one thing we need to keep in mind, what is different from parapneumonic empyema to this tuberculous empyema is the associated pulmonary fibrosis, or this patient might have undergone resection for pulmonary tuberculosis, and because of this the lung is not getting re-expansion properly, as we see in the cases of parapneumonic empyema. So these are the few features of pulmonary tuberculosis complicated with empyema. On left side we can see a large collection, on right side the tuberculosis with air fluid level on right side. So this is another X-ray tuberculous lung disease along with empyema. Now if we see the pleural infection of tuberculosis, we can divide them in like tuberculous pleuritis or tuberculous empyema, and the empyema complicated after tuberculosis therapy. Now first is tuberculous pleuritis. The pleural space is the second most common site for extrapulmonary tuberculosis, and subpleural pulmonary lesion, when they get ruptured into the pleural space, they cause the infection in the pleural space. The clinical feature, as we know, it's the fever, weakness, cough, chest pain and dyspnea. This pleural effusion is developed because of the increased capillary permeability and decreased lymphatic clearance of the fluid in the pleural space. Diagnostically, we can assess the pleural fluid for stains and culture and pleural fluid ADA level. Pleural biopsy, one of the important diagnostic parameter, we can assess directly or nowadays by VATS, and we can confirm the pleural tuberculosis. Treatment in this stage, tuberculous pleuritis, most of these patients, they respond well with proper anti-tuberculous treatment. Sometimes if this pleural correction, if they don't respond well to this AKT, they may get converted in a loculated collection which ultimately requires thoracocentesis ICD or in very late stage for decortication. Tuberculous empyema, the second entity, it is basically because of the pleural reactivation of the tuberculosis in inadequately treated tuberculous patient with AKT, or sometimes because of the development of bronchial pleural fistula in a tuberculous pleural infection, the tuberculous empyema develops. The clinical features are more or less same, like fever, chest pain, cough, copious sputum production. X-ray, if the patient is having bronchopleural fistula, we can find the air fluid level. Other than that, the features of tuberculosis and collection of empyema fluid we can see. Diagnostic pleural fluid, as already we have discussed, we can get the different tests done. Treatment is same as we have already discussed with AKT, drainage of the collection, thoracocentesis, ICD, or ultimately surgical method like VETS or thoracotomy. But few things we need to keep in mind which are different in tuberculous empyema other than this parapneumonic empyema is whether during surgery we need to conserve the lung or not. The lung conservation surgery is generally in the form of drainage of the empyema and decortication of the lung with trying to achieve the maximum expansion without causing much damage of the parenchyma. Generally, in CT we can find if there is no cystic bronchiectasis changes or there is no large cavity, we can get a good result after drainage and decortication and we can conserve the lung. Now, in which cases the parenchymal resection is required? The cases like persistent hemoptysis, associated aspergilloma, extensive bronchiectasis, these are the patients may require lobectomy or pneumonectomy. And after this surgery, as I already discussed, because of the pulmonary fibrosis or lung resection, there is inadequate expansion of the lung which is not getting fully filled the pleural space, and this persistent pleural space may get infected, complicates the infection in this space. To prevent that, we can go for muscle flap, plombage or thoracoplasty. Generally, not these things are done in same sitting, but it's a stage-wise approach. We can plan out drainage and decortication or associated parenchymal resection, and in later stage we can plan out the muscle flap or thoracoplasty. In very ill patient, as we already discussed, we can plan out the open window procedure. Few late pleural and extrapleural complications of collapse therapy, there are of no importance to discuss right now because it was initially used like the plombage therapy, which ultimately cause infectious complications, but right now they are not used, so we'll not discuss in detail. Now we'll see a little bit of diagrammatic presentations of the empyema which are seen on the chest X-ray. On the right side downwards you can see the lamellar collection. On right side you can see lenticular opacity. These are the different forms of this is the apical empyema. These are the different types of empyema pictures what we see routinely on chest X-ray. This is the subpulmonary empyema. The collection is below the lung and above the diaphragm. And one thing we need to keep in mind in very ill patients who are in ICU or they are in supine position, if these patients they develop empyema, we need to find out the X-ray in which right side we can see the opacity, as there is a generalized opacity as compared to the left side, and we can see that approximately 200 to 250 ml of fluid if it is getting collected in this pleural space, we can find out this type of feature instead of a regular opacity loculated collection in normal. Now we'll see the short video of VETS procedure, and we see a few of the steps. Now we'll see a short video of VATS decortication as we see the pre-op CT scan with the empyema complicated with bronchopleural fistula. These are the post-port sites. We are inserting 3 ports in this patient with the 1 port in the 5th intercostal space in the posterior axillary line, second in the 3rd intercostal space in the midclavicular, and the third one is in the 7th intercostal space in the midclavicular line. We have inserted the scope. We are seeing the collection with the pus pockets and the thickened pill on the video. After doing proper sectioning and draining the purulent material, we will start dissecting with the cautery. We identify proper plane between the pleura and the normal lung parenchyma, and see we are creating a space between this pleural pill and the parenchyma. We are dissecting it. After grasping the pleural pill, we are dissecting with the suction cannula, we are dissecting with the cautery, we dissect it with even the peanuts. As and when required, sharp and blunt dissection is required to find a proper space and to clear the pill overlying the lung. We take the debris out of the cavity. In between, we ask the anesthetist to re-expand the lung with proper PEEP so that we can find out how much the lung is getting expanded, and we find a better plane in other places also. So we are removing the debris with the help of cautery. So this is something, a small video of VATS procedure. So VATS, I must say, it's a boon to such thoracic patients, and if indicated, if we do it in indicated patients, it gives us a great results. Thank you.